today about very few salient points about the urolithiasis. You all know this is one of the most or the oldest disease that has affected the mankind, and the incidence, the worrying thing why I have chosen this topic is the urolithiasis incidence is rising globally. The trend is seen in all countries, and which we cannot simply explain by widespread availability of imaging. The common reason that is given that this rising incidence is probably because of the widespread availability of imaging, but that's not true. After careful statistical analysis, they have seen that this incidence is rising. And as you know, this is one of the oldest diseases that has affected mankind, and the evidence to that comes from the study of Egyptian mummies. And this is one of the study which I reviewed, which shows that out there they detected 4 cases of urolithiasis in thousands of examined mummies, which led to the conclusion that the stone disease must have been less prevalent in the ancient Egypt. So that means even if it is an ancient disease, the prevalence was not that much. But if you look at today's textbook, the standard textbook of urology like Campbell Urology, so what did they say? The prevalence of estimation has come to 8.8%, and 8.8% of their population is affected by the stone, which is a very, very high prevalence rate. And this rise in the prevalence is a global phenomenon. Not only in the rise, there is a lot of changes in the epidemiology of the stone disease of late. What is these changes? One is the incidence is rising globally, and it is no longer uncommon in women. Previously, the men were 3/4 of the diseases was affected by males, and 1/4 was in women. But today it is gradually becoming gender neutral, and it is also affected the obese. It is more common in diabetics, it is more common in hypertensives, it is more common in dyslipidemics, and stone sufferers also suffer more from coronary artery diseases. So these epidemiological factors have led to a lot of hypotheses that why this is associated with coronary artery disease, hypertension, dyslipidemia. This is an endoscopic picture. When you push an endoscope inside the kidneys, what we see is a papilla like this, and there are concretions like this, which is popularly known as Randall's plaque. But when we do a histology, we find that these Randall's plaques are in the interstitium of the medulla, not in the duct of Bellini's or the nephronal lumen. It is not inside the lumen of the nephrons, but it is outside. So why these calcium phosphate depositions in the interstitium of the papillas is probably an atherosclerotic phenomenon which is occurring in these arteries which are there in the papilla of the nephron, and these atherosclerotic plaques are gradually eroding into the lumen of the pelvic system, and on which the crystallization grows. So if this genesis is true, then we can definitely say that this is a vascular phenomenon, primarily a vascular disease, which explains its increased association with hypertension, dyslipidemia, and coronary artery diseases. So it's a lifestyle disease. So when a patient comes, in addition to the advising him to drink more water, you need to advise him to take regular exercise also. So this is a practical point. Which is the best test today? Which is the best imaging today available for detecting kidney stones? And out of all these stones, we all know that how to suspect renal colic is a straightforward things. It is a classic pain pattern which spreads from loin to the groin. And the test usually advised is a urine test and an ultrasound of the abdomen. And of course, there is a lot of popularity of this investigation, that is non-contrast CT of KUB, which has certain advantage I will just discuss. So general urine tests can detect hematuria, because microscopic hematuria is associated with almost 85% of the renal colic patients. And a diptychs test to reveal nitrites, which is an indirect indication of an infection, is a very important marker. Because stone associated with infection is a different ballgame, and its treatment line has to be a little different. This NC-stick KUB, which enjoys a popularity today over standard investigations of ultrasounds, is because it gives an idea about the composition from the Hansfeld units. If the Hounsfield unit is less than 900 or less than 600, say, it is more likely uric acids. And similarly, if it is less than 900, then only you can treat them by extracorporeal shockwave lithotripsy. But if it is more than 1000, then extracorporeal shockwave lithotripsy won't work and is probably spoiling time and money. Similarly, skin to stone distance, if the patient is obese and the skin to stone distance is more than 9 centimeter, then ESWL won't work properly. So these are the reasons, and it is if you do take a standard X-ray KUB, almost 50% will not be seen. But whereas NCCT is very sensitive, and almost all stones are detected by NCCT of the KUB. That is why it has become the investigation of the choice. Nonetheless, ultrasound of the KUBs is still useful because it's widely available. It can be done in pregnant and young children, and but it cannot show an ureteric stone in many instances. It misses ureteric stones in many instances. However, it is commonly employed. Once you diagnose, there are two lines of management. So either you can management by conservatively and there is management by surgical interventions. We need to know what are the red flags where surgery is a must. So these are the things. If it is an obstructing stone with any sign of sepsis, like a positive dipstick test, or there is a raised count, or there is fever, or there is a clinical evidence of florid sepsis in form of hypertension. So these are the situations which need some urgent decompression of the kidney. Similarly, obstruction to the solitary kidneys or solitary functioning kidney, obstruction in the kidney with pre-existing renal compromised functions, bilateral stones with anuria. So these are the situations, these 4-5 are the situations which needs urgent surgical interventions, and there is no scope of conservative treatment. But if this is not there, then we can always, if that is a small stone, we can always take a conservative treatment. So what are the conservative treatments? I will come to that, but can we make an intelligent guess which are the real candidates for conservative treatments? The guess is primarily depends on the size of the stone. If the size of the stone is around 4-5 millimeters, there is a high probability they will pass with medicines like hydrations, medicines like alpha-leucins, tamsulosins, and silodosis. And similarly, if the location of the stone is in the lower part of the ureter, they are more likely to pass. Similarly, the compositions like uric acid stones are more likely to pass with medications. And if there is a previous history of stone passage, those patients are more likely to pass with conservative treatment. So what is the drugs used in the medical expulsive therapy or conservative treatment? Is primarily the alpha blockers, which are primarily used for the treatment of the prostate. And the drugs like tamsulosins, silodosins, so they can relax the smooth muscles in the lower ureter and helps in passes. There was a period of popularity of nifedipine, a calcium channel blocker, which also relaxes the lower ureter. And steroids has also been used like the diflazacort. But what happens, there are double-blind trials which shows that if you combine alpha blocker with the steroids, the stone passes quickly, but the ultimate expulsion time is same. I mean, the expulsion rate is same, but they expel quickly. So, what should we instruct to the patients when they are being managed by conservative? They should report to emergency if there is any evidence of fever or if the colic is uncontrolled. What drug they should take in the case of colics, that should be clearly instructed, and they should continue with the drugs that are used for medical expulsive therapies, and they should preferably strain the urine so that they can collect the stone if they pass it. And of course, they should do a follow-up X-ray or CT or ultrasound at the end of 3 to 4 weeks. And if the stone does not pass by that time, that needs surgical intervention. So who needs urologist referral? Uncontrolled colic, any sign of infection, stone which are more than 7 millimeter, which are less likely to pass by the medical expulsive therapies, stone which does not pass at the end of 3 weeks of a conservative trial, and patient with continued microscopic hematuria, even if the stone has passed, need an urologist opinion. So, what are the surgical options? We will briefly describe the surgical options today, and these are the surgical options: ESWL, PCNL, rigid ureteroscopies, flexible ureteroscopy, which is otherwise called retrograde intrarenal surgeries, and laparoscopic surgery and open surgery are very rarely used. So this is a picture of an ESWL machines. What the ESWL machines? They have a shock wave source, and these shock waves are concentrated by this fluid medium here to be concentrated at a focal point. So what is our job? We put the patient in this table, adjust this motorized table in such a way that the stone is located at the focal point of this shock wave generator. And when this shock wave is fired, uh, they pulverize the stone, and the stones are small size, they should pass. So what is the necessity? The necessity is the stone should be soft, or the hospital unit should be less than 900. They should be relatively thin patients, and they should not be too obese, and there should be no associated obstruction or infection. So in those situations, you can definitely do ESW. So this is an example. This is a stone about say 1.5 centimeter, 2 centimeter, located in a system which is functioning well and is a dilated systems, and it has cleared. So, but what we need to know is the stone burden should be less than 1.5 centimeter. If the stone burden increases more than 2 centimeters, then the success rate of ESW drastically drops. So it's seldom used for the stones which are more than 2 centimeter. So the mainstay of the treatment is the PCNL. So this is the picture of a rigid nephroscope. So what do you do? I'll just briefly describe you the procedure. So what you do is you put the patient in the lithotomy, pass a cystoscope, and see the ureteric orifice and pass an ureteric catheter. After this retrograde ureteric catheterization is over, we turn the patient prone. So once we turn the patient prone and put a little bit of dye through the ureteric catheter that we have pre-placed, we can get an anatomy of the pelvic alysial system and decide where exactly we should puncture so that we can access the kidney. So once we have done that, we puncture it, pass a guide wire through it, and over the guide wire, there are serial dilators is done. Initially, we dilate with initial dilators, and then subsequently, we dilate it with metal telescoping dilators. So once there is dilatation is over, we pass a plastic sheath like this, which is called amplage sheath, and once the amplage sheath is in the positions, so we have an access from the outside to the interior of the kidneys. So once we have an access to the interior of the kidney, this is the amplage sheath has been put here. So once we have done that, we look inside and look at the stones, and once we find the stones, small stones can be picked up. If they are big stones, we can break it. There are several energy sources available today, laser and pneumatic lithotripsy, and we break it into pieces and take it out. So this is the basis of PCNL. So this is an example which has multiple stones throughout the kidneys which are punctured, and we have taken it out through one punctures, and this is the nephrostomy tag, and this is the double J stent in place. So the rigid ureteroscopies with endoscopic lithotripsy is the mainstay of the treatment for the stones which are located in the lower part of the ureter or in the middle part of the ureter. So this is the picture of the long rigid ureteroscope. And once we pass it through the bladder, to the urethra through the bladder and go and see the stone, we can break it into multiple energies available today. And the best energies, this is the pneumatic lithotripsy, which can be. So you can do it, you can pass the cystoscope and you do. I will not spoil time here. This is another situation where you can get into the bladder and grab the stone and take it out also. So these are all short videos of these procedures of ureteroscopies. But what we like to stress is today the mainstay of the treatment is through the laser. So this is the new machine which we have acquired in our hospitals. This is a thulium fiber laser. So what you do is once you are inside the ureter, is the sound আসছে কি sound আসছে কি আসছে না?
Yes, sir, we can hear you.
We can hear. So once you have once you are there inside, we can fragment the stones with application of the laser fibers. So the laser fragments the stones. The small stones can be removed, or they can be left in place to be passed in a course of time along the side of the digestate. Can I request everybody to keep it mute? So this is the latest gadget. This is RIRS. This is the RIRS, which is in which we pass a flexible scope. This animation shows that we have passed a flexible scope, and once you have the flexible scope in, you can put a laser fiber through that and fragment it to pieces, and all these pieces can be removed. So all these gadgets has been acquired, and we have already started doing it here. About 4 or 5 cases we have already done. Uh, so this is about RIRS, and if these flexible ureteroscopes have come in several makes today. There is a plethora of instrumentations available, and with these we can get into the inside the kidneys and can look in any nooks and corner of the kidneys. And if there is a small stone, we can put this laser fiber and break it into small pieces. So this is the latest surgical technique that is available uh, for small stones located in the kidneys. Laparoscopic surgeries has lost its popularity for stones, but nonetheless, stones like the mid-ureter, which are so large, can be removed. And this is also the open surgery has also very rarely we need it today. But if the stone is so big, occupying almost every calyx, we can do something called anatrophic nephrolithotomy, which is still relevant for large, very large stones occupying almost all calyxes. Uh, so what can I advise to the patient to prevent recurrence? As you all know, the stones are very prone to recurrence. Almost 50% of the stones patients, if you follow for 7 years, will come back with recurrence. So the blanket advice that is given to prevent recurrence is adequate hydrations. Dietary calcium should not be restricted, especially milk and milk product. In fact, two glasses of milk a day is a helpful adjunct. The reason is the calcium in the diet will chelate oxalate inside the lumen and will prevent oxalate from getting absorbed. So the oxalate level will not go up, and the incidence of stone diseases will come less. But if you are restricting calcium, more of oxalate will get absorbed and there will be more incidence of stone diseases. Similarly, dietary intake of sodium need to be restricted, because sodium, when excreted through the nephron, also drags a calcium ion as its companion. So we need to restrict sodium, and we should need to restrict animal protein, because the animal protein will not only cause more of uric acids to go in the urine, it will also turns the urine pH uh, to acidic, so that there is more of precipitation of uric acid stones. And specific advices needs analysis of the stone and a 24 hours metabolic evaluations for estimating calcium, oxalate, uric acid, citrate and phosphate. And what I need to emphasize is hyperparathyroidism is a rare cause of recurrent stones. The commonest cause is idiopathic hypercalciuria. So what about asymptomatic stones? Sometimes there are stones which are just detected by an ultrasound or by a CT scan, which is done for some other purpose. So they need not be treated if they are less than 5 millimeter in size. If they are in the lower calyx, especially in aged patient, even if more than 5 millimeter in size, and they need to just follow up 6 monthly. And if you are suspecting it to be an uric acid stone, you can try an alkalinization. So which asymptomatic stones need to be removed? If it is more than 5 millimeters, it need to be removed. If the patient has a single kidneys, or there is an occupational need for the stone-free status like airline pilots, military personnel, drivers in the train, etc. And of course, if it is causing obstruction or if it is causing recurrent urinary tract infections, these small stones also need to be removed. So the key points in today's talk: urolithiasis with concurrent UTI is a potentially life-threatening emergencies, and these patients should straight to the emergency departments for treatment. And patient with single kidneys, bilateral obstruction, anuria, or severe premorbid renal failures should be sent to the emergency department, and they should be promptly discussed with an urologist. Non-steroidal anti-inflammatory drugs provides the most effective analgesia in renal colic, and the regular use of tamsulosin improves stone passage rates. So large stones or patients who have failed in conservative management should be referred to the urologist for surgical intervention. Non-contrast CT scan of the QB is the investigation of the choice in a suspected renal colic. And patient with uncomplicated stone less than 7 millimeter in size should be considered for conservative management. But this depends on the patient's preference and the overall clinical scenario. Patients with urolithiasis should be well hydrated and should have a diet which is low in salt, low in oxalate, low in animal protein. Stone analysis should be an integral part of the management to give a specific dietary and medications to prevent recurrence of the stone. So thank you very much, friends. Any question I can take it up.